Hello everyone, this video is about rapid sequence intubation, a critical technique used in emergency rooms, operating theaters and ICUs. And these are the topics I'm going to cover in this video. Let's start by defining rapid sequence intubation. Rapid sequence intubation, or RSI in short, is a technique of intubation where we follow sequential approach to achieve rapid control of airway while minimizing the risks of regurgitation and aspiration of gastric contents. We also call it rapid sequence induction and intubation. This technique aims to minimize the time between administering anesthetic drugs and securing the patient's airway. RSI was originally described in 1961 by Dr. Brian Selick. His method is now referred to as classical RSI. Classical RSI begins with gastric decompression via orogastric tube placement and removing it immediately. This was done to reduce the volume of gastric content that can cause aspiration. It was followed by thorough preoxygenation to maximize oxygen reserves. Patient is then positioned supine with slight head-down tilt to leverage gravity in preventing regurgitation. Anesthesia was then induced with weight-based dosing of drugs like thiopental or volatile agents, combined with fast-acting depolarizing neuromuscular blockers such as succinyl choline to achieve rapid paralysis. The Selick maneuver, or firm cricoid pressure, is applied before the loss of consciousness and maintained at 30 newtons of force to mechanically occlude the esophagus against the vertebrae. The aim is to prevent gastric content from leaking into the airway. Endotracheal intubation is then performed immediately upon observation of succinyl choline-induced fasciculations. Direct laryngoscopy with curved endotracheal tube is used for intubation with cricoid pressure still applied. The defining feature of classical RSI is the avoidance of positive pressure ventilation between induction and intubation to prevent gastric insufflation. The entire sequence is executed as a single continuous process, typically completed within 60 seconds from drug administration to confirmed tube placement. As with any intubation, the indication stems from the fact that the patient cannot maintain his or her airway or they are prepared for general anesthesia. Apart from this, RSI is particularly indicated when the patient is not fasted, has gastrointestinal pathology, or has raised intra-abdominal pressure. There are many clinical conditions that can lead to increased risk of gastric aspiration, as shown in this slide. The contraindications can be divided into absolute and relative contraindication. Absolute contraindications include total upper airway obstruction and total loss of facial-oropharyngeal landmarks that require surgical airways. The relative contraindications include situations where we anticipate difficult airways like difficult back and mask ventilation, difficult laryngoscopy, and difficult intubation. If we anticipate that we won't be successful in intubating the patient, we need to go the alternative route like awake fiber optic intubation. RSI could cause more harm in such situations if we fail to intubate the patient on time. Also, if the patient is arrested or completely unconscious, we don't need RSI. We proceed with CPR and intubate the patient without delay. When it comes to performing RSI, it's not a one-man show. As the name suggests, we should be able to rapidly perform tasks in quick sequence to achieve successful intubation. So a well-coordinated team and a sound knowledge of the procedure is very important. An easy way to go about it is to follow the 7 P's of RSI technique. The 7 P's are preparation and planning, preoxygenation, pretreatment, paralysis with induction, positioning and protection, placement with proof, and post-intubation management. The approximate time frame within which this task should be completed is also given here. We will look into each one of them next. RSI is a high-stakes procedure, so preparation is a key step. We should think of patients, equipment, drugs, backup plans, and team roles. For this, mnemonics like StopMed can be used to ensure nothing is missed during the preparatory phase of RSI. The S in StopMed stands for suction. Before beginning intubation, we must ensure that the suction equipment is immediately available and functioning properly to clear any vomit, blood, or secretions that could obstruct your view or lead to aspiration. T stands for preparing tools for intubation, including laryngoscope with appropriate blades such as Macintosh size 3 for adults, endotracheal tubes in correct size plus one size smaller as backup, a stylet, a bougie, and an alternative airway devices like laryngeal mask airway in case of difficult airway. It should also include tools for difficult airways like front of neck access. O is for oxygen, where we ensure oxygen is readily available for pre-oxygenation and ongoing ventilation. Along with oxygen, devices like ambu bag should be available in working condition. P stands for positioning the patient optimally for laryngoscopy. For most patients, the sniffing position is ideal and is achieved by flexing the neck forward while extending the head backward, aligning the oral, pharyngeal, and laryngeal axis to create a clear line of sight to vocal cords. In obese patients, this is modified to a ramped position, where the upper body and head are elevated on the blankets or a specialized ramp until the external auditory meatus aligns horizontally with the sternal notch. For trauma patients requiring cervical spine stabilization, the neck is immobilized while carefully adjusting positioning to balance airway access with spinal protection. M stands for monitoring. Before administering any medication, we should confirm that all monitors are in place and functioning. And these monitors include pulse oximetry to track oxygenation, ECG for cardiac monitoring, blood pressure measurement to detect hypotension or hypertension, and capnography to verify proper endotracheal tube placement after intubation. A is for assistant or airway team preparation. For this, we designate clear roles for each team members, with one person handling the airway, another managing medication, a third watching the monitors and calling out vital signs, and an additional assistant available to apply cricoid pressure or stabilize cervical spine in case of spine injury. The I in StopMed stands for IV access, which should be secured preferably with one large bore catheter or cannula to ensure rapid administration of induction agents and emergency medication. And also we need to consider placing a second IV or central line in unstable patient who may need fluid resuscitation or vasopressors. Finally, D stands for drugs. All the drugs should be prepared and labeled, including an induction agent like etomidate or ketamine, a neuromuscular blockers such as succinyl choline or Roaronium, and any adjuncts like fentanyl or lidocaine, ensuring doses are calculated and drawn up to avoid delays during critical moments of intubation. Along with this, emergency drugs like atropine, adrenaline, and other inotropes should be prepared. One of the ways to prepare for RSI is to adopt a checklist like the one given here. Please pause the video and go through it. At this point, it is noteworthy to mention about premedication and strategies that can be used to reduce gastric aspiration if the time permits. The most important one is of course adequate fasting for elective cases. To further reduce the risk of gastric aspiration during intubation, premedication can be used. Non-particulate antacids like sodium citrate are used to neutralize gastric acid, while an H2 blockers like ranitidine can decrease gastric secretions. Prokinetics like metoclopramide enhances gastric emptying by increasing lower esophageal sphincter tone while providing antiemetic benefits. The second step of RSI is preoxygenation. Preoxygenation involves replacing the nitrogen that predominantly fills the functional residual capacity with oxygen, a process often described as nitrogen washout, denitrogenation, or oxygen wash-in. The primary goals of preoxygenations are to increase the body's oxygen reserve, thereby providing additional time to secure the airway and to reduce or eliminate the need for mass ventilation during induction. Several methods can be used to achieve effective preoxygenation. One commonly used technique is the administration of 100% oxygen via a tight-fitting face mask or non-rebreather mask for 3 to 5 minutes. Alternatively, the patient may be asked to take 8 deep breaths or vital capacity breaths within 60 seconds. The preoxygenation is expected to maintain an oxygen saturation of at least 90% up to 8 minutes of apnea time. During laryngoscopy, apneic oxygen can also be provided by delivering oxygen via nasal cannula at the flow rate of 10 liters per minute. In morbidly obese patients, continuous positive airway pressure or CPAP or PEEP may be used to improve oxygenation during this phase. The third step in RSI is pretreatment or premedication, which refers to the administration of specific medications before induction agents and neuromuscular blockers. The aim of pretreatment is to mitigate sympathetic responses to laryngoscopy and intubation like hypertension, tachycardia, and ICP rise. In pediatric patients, stimulation during laryngoscopy or tube placement can trigger a parasympathetic response leading to abrupt bradycardia or even asystole. So pretreatment is considered in patients at risk of raised intracranial pressure, significant sympathetic stimulation, or bradycardia. We can use LOAD or load as a mnemonic for drug use as pretreatment. L stands for lidocaine, O stands for opioid like fentanyl, A stands for atropine, and D for defasciculating dose of non-depolarizing muscle relaxant. Lidocaine is administered to blunt sympathetic response to laryngoscopy, preventing dangerous spikes in intracranial pressure while also helping to mitigate bronchospasm in reactive airway diseases. Opioids like fentanyl serves dual purposes. They attenuate the hemodynamic stress response to intubation, reducing tachycardia and hypertension, while also providing essential analgesia. Atropine plays a particularly vital role in pediatric patients, where it prophylactically counters the profound vagally mediated bradycardia that commonly occurs during airway manipulation. Finally, a defasciculating dose of non-depolarizing muscle blockers such as 0.01 mg per kg of Roaronium may be given when succinyl choline is used to prevent the muscle fasciculation that can cause increased intragastric pressure. However, pretreatment is not always required and is used selectively based on patient's condition. The fourth step is paralysis and induction. Induction agents induce unconsciousness, while paralytics or neuromuscular blocking agents relaxes the muscle, facilitating intubation. This combination minimizes the time the airway is unprotected and allows for quicker, more controlled placement of endotracheal tube. Propofol is commonly used for patients who are hemodynamically stable. In elderly or hypovolemic patients, the dose of propofol should be drastically reduced. Ketamine is increasingly used in pre-hospital settings and in unstable patients because it elevates heart rate and blood pressure. With it, secretions can increase and may necessitate the need of suctioning or premedication with anti-Psylocke such as atropine or glycopyrrolate. Etomidate has a very limited hemodynamic effect and it is used mostly in patients with heart diseases or heart failures since it provides stable hemodynamics. However, its use has been limited by concerns of adrenal suppression and there is also a limited availability in some countries. Thiopentone has the most rapid and predictable effect with less hemodynamic instability than propofol. However, there may be issues with poor availability and harmful sequelae following extravasation or intra-arterial injection of thiopentone. Midazolam may also be used, although the time to the effect may be very prolonged. It is primarily used to provide amnesia rather than true anesthesia. Despite the choice of drug, careful dosing is more important than the choice of drug. In shocked patients, a very modest dose of hypnotics or induction agent may be sufficient as the drugs can easily lead to circulatory collapse and cardiac arrest. So, resuscitation drugs should also be available. When selecting paralytic agents or neuromuscular blockers for RSI, rapid onset is crucial to minimize the risk of aspiration and hypoxia. Additionally, quick recovery is desirable to facilitate ventilation if intubation fails, while minimal hemodynamic and systemic effects help maintain patient stability. For many decades, succinyl choline has been the standard of care for RSI. In full dose of 1 to 2 mg per kg, it produces fasciculations, paralysis, and excellent intubating conditions within 1 arm brain circulation time of 15 to 45 seconds. Adverse effects are well recognized, although uncommon. Myalgia is the most common side effect, but bradycardia, hyperkalemia-induced cardiac arrest, anaphylaxis, and triggering of malignant hyperthermia can all occur. Many clinicians still continue to use succinylmethonium or succinyl choline unless there is an evidence of susceptibility to one or more of these adverse events. For example, it is not used in patients with recent burns, spinal cord injury, or history of muscular dystrophy. Roaronium is an alternative agent used for paralysis. In high doses in a range of 0.9 to 1.6 mg per kg, profound relaxation is obtained within 45 to 60 seconds, which is comparative to succinyl choline. One disadvantage, however, is the lack of fasciculations, so other methods of ensuring adequate laryngeal paralysis must be used. The prolonged duration of action must also be taken into account if the airway is likely to be difficult and if the specific reversal agent is not available. Anaphylaxis is still a possibility, but the risk of myalgia, hyperkalemia, and malignant hyperthermia are avoided. A further benefit of roaronium is the existence of specific reversal agent. Sugammadex, a reversal agent for roaronium, is useful for restoring neuromuscular function rapidly if required by the difficult airway plan. A dose of 16 mg per kg can rapidly reverse the effect of roaronium, but the usage may be inhibited by its high cost. Other common neuromuscular blocking agents are too slow in onset to provide sufficiently rapid intubating conditions and so would require prolonged mass ventilation of the patient. The fifth step in RSI is positioning and protection. Proper positioning ensures optimal ergonomics for successful mask ventilation, laryngoscopy, and intubation, while protective measures aim to prevent aspiration during the procedure. The positioning of the patient should be managed before starting the induction. After induction, we must ensure that the position is maintained during the intubation to ensure good visualization of glottis. We have already discussed the sniffing position of normal patient, ramping up in obese, and manual inline stabilization in cervical spine injury. The other position aspect of importance here is the BURP maneuver or burp. BURP or burp is an acronym for backward, upward and rightward pressure, and it involves applying this specific pressure to the thyroid cartilage of the larynx. It is used to improve visualization of vocal cord during laryngoscopy. It should not be mistaken for Silic maneuver or cricoid pressure, which we will see next. The protection component of RSI focuses on preventing gastric aspiration, primarily through the application of cricoid pressure, a maneuver involving downward pressure on the cricoid cartilage to compress the esophagus against the cervical vertebrae. This theoretically occludes the esophageal lumen, reducing the risk of regurgitation and pulmonary aspiration. The recommended force is 10 newtons or 1 kg applied at the beginning of induction when the patient is awake. The pressure is then increased to 30 newtons or 3 kg after the loss of consciousness until the endotracheal tube placement is confirmed. However, the utility of cricoid pressure remains debated. While it is widely practiced, critics highlight several limitations. The first one is that it may impair laryngoscopic view and lacks robust evidence for efficacy as per the 2015 Cochrane review and carries the risk of esophageal rupture if vomiting occurs. Additionally, inconsistent application of force by the providers and patient discomfort further complicates its use. Thus, while cricoid pressure persists as a standard precaution, its universal adoption reflects tradition more than definite evidence. Here are some recommendations for some of the notable anesthesia society. The sixth step in RSI is placement of endotracheal tube along with confirming that it is inside the trachea. A curved endotracheal tube of appropriate size is inserted under direct laryngoscopy. If cricoid pressure is applied, it should be maintained during laryngoscopy and immediately released if the laryngeal view is obscured. Along with that, we can use BURP or burp maneuver to enhance the view of vocal cord. Once the tube passes through the vocal cord, its position is confirmed by direct visualization and the curve is inflated to seal the trachea, after which cricoid pressure is also discontinued. The ET tube is then securely fixed at the lips or teeth using the tape. Correct placement is verified through multiple methods. These are direct visualization of tube passing between the vocal cords, bilateral chest rise and fall with ventilation, 5-point auscultation, consistent end-tidal CO2 or ET-CO2 waveform, sustained oxygen saturation improvement, visible condensation within the tube during exhalation, and finally radiological confirmations using X-rays or point-of-care ultrasound. There will be rise and fall of reservoir bag if the patient starts breathing, if we are using Bain circuit or circle system in open position. Continuous ET-CO2 monitoring remains the gold standard for real-time confirmation in both operative and emergency settings. The final step in RSI is post-extubation care. Following successful intubation, continuous monitoring is initiated, which includes ECG, oxygen saturation, blood pressure, and capnography to ensure that endotracheal tube is not displaced. Additionally, measures such as nasogastric or orogastric tube placement is placed to decompress the stomach if there is still a risk of aspiration. Chest X-rays are performed and also arterial blood gas analysis are performed as needed. Mechanical ventilation is commenced and sedation and appropriate neuromuscular blockades are maintained to ensure patient's comfort and safety. RSI, while essential in emergency airway management, it carries several risks. Hypoxemia may occur due to prolonged apnea or failed intubation, emphasizing the need for effective preoxygenation. Aspiration remains a critical concern too, particularly if gastric contents regurgitate during the procedure. Hemodynamic instability like hypotension, and raised ICP can result from induction agents or sympathetic response to laryngoscopy. Airway trauma or esophageal intubation may arise from technical difficulties, while failed intubation, a life-threatening scenario, demands immediate rescue strategies like supraglottic airway insertion or surgical options. Medication-related adverse effects like anaphylaxis and hyperkalemia from succinyl choline can also occur. Post-intubation pneumothorax or tube dislodgement may also occur. Now, let's briefly look at the difference between the classical RSI and the modified modern version. Classical RSI traditionally includes gastric suctioning with NG or OG tube before intubation, aiming to reduce stomach contents, while modern RSI typically skips the routine suctioning unless the patient is actively vomiting. This is due to the concerns about aspiration risk from improper tube placement or vomiting, as well as the potential for esophageal perforation during insertion. The evidence does not strongly support routine gastric compression for all patients undergoing RSI. For preoxygenation, classical RSI uses the standard 100% oxygen via face mask for 3 to 5 minutes, whereas modified RSI often extends that with high-flow nasal cannula during apnea to maintain oxygenation longer, especially in patients prone to rapid desaturation. While traditional teaching cautioned against back mask ventilation due to concerns about gastric insufflation and aspiration, studies have shown that it can be effective and safe in preventing hypoxemia during the critical interval. So in modern RSI, gentle back mask ventilation is often used between induction and laryngoscopy, even in patients who are not initially hypoxemic. In terms of positioning, classical RSI sometimes employs a slight head-down tilt to theoretically prevent gastric contents from reaching the airway, but modified RSI prefers a position which improves laryngoscopy. When it comes to induction drugs, classical RSI relies on thiopentone and succinyl choline for fast paralysis and intubation, while modern RSI adjusts choices based on patient stability, for example, using ketamine for shock, propofol for stable patient, and Roaronium as an alternative to succinyl choline when hyperkalemia is a concern. Dosing in classical RSI is weight-based and fixed, whereas modified RSI often tailors doses, especially in critical ill patients, reducing sedatives in shock to avoid cardiovascular collapse. Cricoid pressure is a standard part of classical RSI, applied continuously during induction and intubation to block regurgitation, but modified RSI may skip or release it if it interferes with the view during laryngoscopy. Finally, this diagram summarizes all that we have learned in this video. You can read about RSI using the citation provided. That's all, and feel free to leave a comment if there's anything you didn't get it. Thank you.